Bismillahirrahmanirrahim. First, I would like to thank very much Dr. Khalid and Dr. 𝗏 and all the team for inviting me here. I'm going to talk about endovascular thrombus management in acute limb ischemia. Before I talk, I would like to invite everyone for our coming conference in the vascular art, which will be held in Jeddah next month, 29th and 30th. You are all more than welcome. First, acute limb ischemia, of course, resulting from the sudden loss of arterial perfusion. It's about 22 to 26 per 100,000 per year. 15 to 50% result in major amputation, and 15 to 20% die within the first year. Mortality is not necessarily related to the operation, but due to inherited comorbidities. This is the Rutherford classification for acute limb ischemia. Of course, it's 1, 2A, and B, and 3. Of course, you all know this better. The etiology can generally be categorized into whether in situ arterial thrombosis, whether embolism, whether aneurysm, which can be present with both thrombosis or distal embolism. Surgical revascularization has been the gold standard for so many years. But with advancement in the thrombotic therapy and catheter-based techniques, endovascular approach have emerged as first-line therapy in treatment of acute limb ischemia by many of the experienced. Indications: thrombotic or embolic occlusion of native artery or bypass graft with new onset of claudication or limb-threatening ischemia. Of course, less than 14 days, otherwise it will be subacute. The contraindications: bleeding disorder, intracranial hemorrhage, stroke, head injury, esophageal varices, pregnancy, surgery, all the usual contraindications for thrombolysis. The advantage of endovascular therapy, this is very important. It's not just less invasive option in the acute fragile patients, but also it was realized that residual thrombus has been demonstrated in large fraction of vessels after open surgical thrombectomies, because you are not always in a situation that you do angiography after you finish, but you just remove the thrombus, you have backflow, and you close, especially in the middle of the night, you know. The most important point that the endovascular option often helps to identify the underlying lesion, the underlying causative lesion. What are the endovascular treatment options? Whether catheter-directed thrombolysis, whether the percutaneous mechanical thrombectomy, whether the percutaneous aspiration thrombectomy. The catheter-directed thrombolysis, of course, using TPA infused over some hours, sometimes days, and either retrograde or antegrade. The pharmacomechanical thrombectomy and the percutaneous aspiration thrombectomy can be done alone or sometimes with the catheter-directed thrombolysis. The goal is thrombus maceration and removal. Pharmacomechanical devices are either rheolytic, macerates the thrombus, or rotational or ultrasound enhances. The percutaneous mechanical or aspiration thrombectomies that we all know, not all in the Egyptian market, but most of it. The angiojet, of course, it's rheolytic and aspiration, pharmacomechanical. The jet stream, also from Boston, rotational and aspirational. Trirotola rotational, pharmacomechanical. Amplads, also rotational. Cleaner is rotational and aspiration. Trillis is rheolytic rotational. The ECOS is ultrasound rheolysis, ultrasound enhanced. the 𝗓𝗍𝗀, which is penumbra, vacuum assisted aspiration. The 𝗓𝗏𝗏 is also assisted aspiration, and the 𝗓𝗏𝗃 is rotational and aspirational. This is just some comparison between the angiojet and the jet stream cleaner and 𝗓𝗍𝗀 about the way of the fragmentation, as we mentioned, rheolytic for the angiojet and rotational for the jet stream cleaner. The penumbra is only aspiration, and the thrombus age is the penumbra is not suitable for the chronic thrombus. The first three are, and the atherectomy is only for the jet stream. The thrombolytic is also for the angiojet and the cleaner. You can use this. This is the angiojet. You inject the through the catheter the thrombolytic agent, and then after some times you can start mechanical thrombectomy. This Pearl registry was done for about 6 years, 34 institutions, and the result was that the result supported that the use of pharmacomechanical thrombectomy as a first-line treatment for acute limb ischemia, providing a rapid reperfusion of the extremity, reduced procedure time, and acceptable risk profile without compromising the limb salvage. This study was done for the risk of acute kidney injury that can occur during the percutaneous pharmacomechanical thrombectomy, and the result was this acute limb injury is associated with age, chronic kidney disease, and heart failure. It's not necessarily that occurs in every patient, but the underlying comorbidities. This is the ECOS. It's ultrasound enabled delivery for the TPA. It has some advantage that you can use less dose of the thrombolytic, more localized delivery of the lytic agent, and could be used after mechanical thrombectomy. This is the penumbra. It has many advantages. Maximize the aspiration power, the directionality of the tip of the catheter, and the advanced tracking technology. Has many catheters, tips for small for the peripheral and larger for the iliacs, and larger even for the pulmonary vessels. This is some examples before and after. This one is for the superficial femoral here, and this is one for the popliteal. This is post thrombectomy, and this is for the peripheral. This is the algorithm which was done 2000 for the acute limb ischemia. 1, 2A were recommended for endovascular, and 2B was recommended for surgery direct. This 3 is, of course, non-salvageable. This has changed in 2019. 1, 2A, and 2B also. You can use the endovascular, and if failed, you can use the open. 3, of course, for the non-salvageable. For conclusion, acute limb ischemia is challenging, and surgery, of course, has been first line of treatment for some time, but now review of the current data suggests that reduction of the morbidity and mortality of the endovascular, and based on this, we can consider the endovascular is a first line of treatment, is appropriate and acceptable. Thank you very much.